Hello and welcome everyone. Today we'll be discussing a very important topic, that is the nerve conduction studies, which are very commonly done in our ICUs for various indications. So this is basically the schematic diagram of a basic nerve structure. There are synapses, there is a cell body, nucleus. The most important thing for us is this axon, which is transmitting the signal to the effector places. There are myelin sheaths in some nerves which help in faster conduction. So this is a basic depolarization that is seen. This is the resting state where the sodium is outside and the potassium is inside. So in a case of depolarization, your sodium enters into the cell, making the outside negative, inside more positive. Then there is a phase of repolarization where the potassium goes out to equalize the charges again, and you get more positive outside and negative inside. So how does this conduction takes place in the axons? So in the non-myelinated ones, the depolarization goes along the axon in this direction. However, in nerves that have myelin sheath, they are protected by this covering, the yellow covering that you're seeing over here, which is called the myelin sheath. The basic objective of this myelin sheath is to act as an insulator. So what it does is the depolarization doesn't go beyond this. So what happens in this phase is there is a conduction of the electricity based on the voltage. So based on the passing voltage, and because it is insulated, the electricity passes as we see passing it in our wires. So the current passes over here without any disruption. But then what is the need for having these nodes of Ranvier? The point is, once you have anything flowing like this, electricity flowing like this, there will be a drop in the voltage. If there is a drop in the voltage, I may not get an adequate response at my effector site. So to keep the voltage intact, we have these nodes of Ranvier, which again depolarize in between and maintain the voltage of the electrical signal. So this makes the transmission very fast because the electrical transmission is much faster than the depolarization that could have occurred. So the axons that do not have these myelin sheath, they do not have this fast electrical transmission or the nodes of Ranvier. So the depolarization passes along like this, with each segment getting depolarized slowly and slowly. So this results in a slow conduction of the electrical signal. But the nerves that have myelin sheath, there is an electrical conductance, and to maintain the voltage, we have this nodes of Ranvier which depolarize and again maintain the voltage of the electrical signal that is being transmitted. So what we get is depolarizations in the nodes of Ranvier, which is called as the saltatory conduction of the electrical signal. Now, nerve conduction uses a bipolar simulator with a negative cathode and positive anode. The depolarization starts under the cathode, triggering the nerve signals. Under the anode, there is hyperpolarization occurring, inhibiting the signal transmission. But the most important for us is the cathode, which creates a negative inside this tissue. This negative created inside the tissue will attract more sodium, thereby making the sodium concentration very high and inducing a action potential by pushing the sodium into the nerves. Now, the stimulatory current flows mainly through rho as resistance extracellular spaces, but that is not the point of our concern. We are not really dealing with the extracellular space. What we want is the electricity to flow through the nerves. The axons depolarize depending on the resistance. Now, this resistance is lower in the larger nerves. So when you are giving a less signal, a less stimulus that will depolarize a larger axon more easily than the smaller axon. So we give less stimulus so that we can capture the larger nerves, the ones which we want to test. Say for example the median nerve and not the accessory smaller nerves going downside. Now larger actions are preferentially stimulated at the lower intensity of the NCS. So this is what you see, there is a stimulus. This stimulus creates the sodium concentration over here, which causes the nerve to depolarize, and this signal gets transduced. Now this is what is happening in the sensory nerve conduction. So sensory nerve conduction test uses a bipolar recording method with the active and reference electrodes placed over the nerve. So this is where the sensors are placed. Potential difference is measured and compared between the active reference and the ground electrode on the patient. Now, compound sensory nerve potential is greatly influenced by the reference electrode's position. So, we give a signal over here and we record it in the nerve terminal over here. Nerve currents are indirectly measured through the volume conduction, where loops of the current in the soft tissue reflect the actual action potential. So, we'll go into the details of this snap. So what we get over here, these are the recording electrodes. This is the stimulating electrode. You are stimulating from here and you are recording here. So stimulus is coming from this nerves and you are recording it over the median nerve. So once you give a stimulus, this is the stimulus. After that, there is a lag time which is called the onset latency. After that onset latency, you get a peak and the recording electrodes. So this peak is called as the amplitude. We also measure the baseline peak difference, the baseline to peak difference, and the duration of the action potential. But mostly in the snap, what we measure is the amplitude and the onset latency. So as you can see here, if all the spinal cord and the nerves are intact, then this is what we'll get is a normal snap. However, if the preganglionic is blocked, then also we will get a normal snap because we were testing this part of the nerve only, not this part. So a preganglionic lesion is not going to be picked by nerve conduction test. It is the postganglionic lesion that we are going to pick. So once there is a postganglionic lesion, what you will get is a picture like this, where there is an abnormal snap. You do not get the action potential that we are expecting to get. This is the setting of a motor. Here you have the stimulus. This is the distal stimulus. This is the proximal stimulus. And here you record on the nerve the contraction and the effect. The active electrode measures the compound action potential, that is CMAP, at the muscle motor point, reflecting the muscle fibers potential. Depolarization starts beneath the recording electrode, causing an initial upward deflection of the sodium at the muscle end plates. The waveform normalizes as the muscle regains its resting membrane potential, with the distal latency marking the fastest nerve depolarization time. Now, distal latency does not directly reflect conduction velocity as it includes the synaptic time. Conduction velocity is determined in the proximal segments by correcting for the distal latency and distance. So just explaining, uh, once you get the signal from here to here, this also includes the synapse between the nerve and the muscle. So there is a lag time between the muscle and the nerve. That is not something which we want to measure over here. We want to measure the nerve conduction. So this part is not included in the testing of the nerve conduction time. To know the nerve conduction time, you check the latency from here, this latency, and the latency from here, and then you measure the distance in time difference between this and this is taken as the conduction velocity. So it eliminates the synapse time because it cancels it out, and what we are measuring is the difference between the conduction time from here to here. So proximal is mainly used to calculate the conduction velocity. So this is the typical CMAP that you're going to get. Distal latencies are crucial for diagnosing nerve disorders, aiding in interpretation of the nerve's function. The CMAP represents the electrical activity of the muscle but does not indicate muscle contraction, which involves the calcium mediated processes and happens much later. The reference electrode placed is on the electrically silent bone, affecting CMAP's waveform, and it's not electrically inactive. Now, normal temporal dispersion in the motor responses means small neurons conduct slower than larger nerves, causing CMAP to elongate and decrease in amplitude over a long segment. This effect is less pronounced in motor than in sensory studies due to the longer duration of the CMAP. This basically means is that in CMAP, as we have seen, the area was very small. There, if you have a lot of small nerves which are conducting very slowly, then the area of the curve will increase, but as such the area of the motor action potential is a slightly longer one, so it is very difficult to detect the effects of the small nerves that are finding. So what we measure here is the latency. This is the distal latency if the stimulus is from distal. If there is a proximal latency, the signal will come a little later. Subtracting these two latencies and the distance between the two electrodes, we are going to calculate the conduction velocity. So this is the area, this is the amplitude, and this is the total duration of the action potential. These are the things which we are going to measure and which are going to help us in our interpretation later on. The next is the F wave. F wave comes from the initial observation of the foot muscles. From this is where the F term comes. It was first seen in the foot muscles. It signifies a retrograde repolarization of the motor axon terminal to the anterior horn cell. Here the signal, the stimulus is given over here. It goes back to the anterior horn cell and the signal comes back again to the muscle. So this later gives us a peak like this. Now the stimulating a motor neuron sends a depolarization both first proximally as well as distally. About 10% of the neurons send a regenerative action potential back to the muscle, which is seen here as the F wave. Standard cathode distal placement can generate F waves without needing to reverse the stimulator polarity to avoid anodal block. F wave generation involves no synapses at the spinal cord level, leading to consistent morphology and latency per axon, but variability across the stimulation due to different neuron pools is seen. Now, F wave generation likelihood is tied to the anterior horn cell membrane excitability and is affected by physiological states or actions like clenching of the teeth, reduction during sleep, and anesthesia. F waves are vital for diagnosing nerve pathologies, especially for assessing the proximal nerve segment. If you want to examine the proximal nerve segment, it can give a very good idea of proximal nerve segment, especially in GB syndrome where the proximal segments are more affected. So here, as you can see, there is an electrical signal. First you get the M wave and later on you get a F wave. So there is a minimum latency, there is a maximum latency, and what we try to calculate is the median one. Now the accuracy, that is a minimum of 10 F waves are analyzed, focusing on the minimum latency to reflect the fastest axon. However, pathological changes might be better represented to the mean or the median F latencies. Now, the chronodispersion, the measures of the latency offering insight to the nerve health variation, indicates how often the F wave occur after a stimulation, which variation suggesting a neuropathic condition. If you see a lot of variation, then it indicates that there is some kind of a neuropathy going on. F wave latency is affected by the limb's length, thus height adjusted calculation is essential for accurate interpretation, especially for diagnosing proximal pathologies, because as is evident over here, the length of the limb is going to be vital. F waves are crucial for identifying demyelinating radiculopathies and assessing the proximal nerve health. They are limited in evaluating specific nerve root and sensory radiculopathies. Their significant diagnostic value is in GB syndrome, where proximal demyelination is very common while distal is usually normal. The next is the H reflex. In the H reflex, from the electrical signal from the sensory nerves, you get a stimulus. Here, the H reflex is named after Hoffman, who first recorded it in 1918 in the electrophysiological version of the clinical ankle jerk reflex, though it may not assess the exact nerve endings as described. It elicited by stimulating the tibial nerve with cathode above the anode in the popliteal fossa, and the recording is done in the soleus muscle. The aim is to selectively stimulate the 1A sensory nerves with a longer pulse duration, that is 1 millisecond, than the usual NCS. While mainly recorded from the soleus muscle, the H reflex can also be elicited from the flexor carpi radialis via the median nerve stimulation. It is useful both in adults and children, and it provides an additional insight into certain disease processes. Assessed through a recruitment curve to reflect a monosynaptic reflex pathway, the H reflex demonstrates the reflex arc and the nerve function akin to a ankle jerk. So here, from the sensory nerves, the signal is going to the spinal cord, from where you're getting a motor signal, and you can see a muscle contraction. So H reflex is something which will come with a lesser stimulus and much earlier. So as is seen over here, initially only the H reflex and appears with low stimulus intensities. As you see here, the intensity of the stimulus is low. So first we get no response. Next we get a H reflex. With increased intensity, what we will see is that the M response, that the C map, is start to appear, while the H reflex will go on reducing. The primary measurement in the H reflex minimum onset latency is affected by the height and the nerve health. Bilateral comparisons is important. Amplitude ratios need to be done, especially in evaluating the alpha motor neurons excitability and the upper motor neuron issues. The H reflex aids in diagnosing S1 radiculopathies, assessing spasticity. However, like F wave, it has specific limitations. Variations in the latency or reflex absence might suggest polyneuropathies and neural disorders, necessitating further clinical and comparative analysis. Next, what we get is something called the A wave, which is very rare. A especially means abnormal. It is a late response observed in nerve conduction. It is notable for its consistent latency and morphology across different stimulus. They differ from F wave, which vary in latency and shape with each stimulus. So it is very similar to the F wave, but here the morphology, as you can see here, is very similar and consistent, not like the F wave, which keeps on varying in intensity. A wave becomes prominent in various neuropathic conditions, including polyneuropathies, radiculopathies, and is an indicator of the nerve dysfunction. The latency of the A wave may be shorter or longer to the F wave. It is very difficult to say if it will be longer or shorter. It can be anything, depending on the specific neural pathway that was used for its generation. Now, A waves arise from abnormal branches of the axon. When stimulated, this branch experience antidromic excitation, then an orthotomic depolarization, resembling an axon's reflex. The proposed A waves result from electrical transmission between axons, especially in the demyelination cases, allowing nerve impulse crosstalk, leading to consistent muscle activation latencies. A wave in the nerve conduction study serve as an important marker for neuropathies, distinguishing them from other late response like F wave, shedding light on the underlying abnormal neural process in the peripheral nerve system. So coming to the technical aspects, this was all the physiological aspects. Now what are the technical aspects of doing the nerve conduction? It is a very simple process, but achieving reliable results is complex because there are anatomical variations, there are technical issues, there are procedural issues, and there is interpretation challenges. Now, standardization across various aspects is needed because there is a difference in the machine setting, the limb's temperature, patient's characteristics, and it is crucial to standardize to get accurate and reproducible results. The important standardization is reliable labs normal value, which is essential for meaningful comparison. Each electrodiagnostic lab must establish its own normal values. For unilateral regions, comparing with the contralateral side is sufficient. Unaffected limb can be more sensitive than a lab's norm. A response of 50% or less than the contralateral limb is considered abnormal and is supported by computer simulation for detecting conduction blocks. Now, what are the components? as we have seen over here, the components are first amplitude. It measures the height of the evoked response, and it is crucial to assess the number of axons conducting the impulses and the efficiency of the neuromuscular transmission. The amplitudes are significant indicators of neuromuscular disorder and directly related to symptoms like muscle weakness and sensory deficits. The time interval for the evoked potential and reflecting the relative conduction rate across the axon. The duration and the amplitude are related. Prolonged duration often means a decreased amplitude. Next is the latency, conduction velocity, and area. First is the importance of the amplitude. Despite being the most informative component in assessing various types of neuromuscular disorders, amplitudes are often neglected. They are vital for indicating neurogenic lesions and their relationship to clinical symptoms. The duration and dispersion. Duration measurement, though less commonly recorded now, remains important for identifying whether the responses are dispersed, which can indicate different pathophysiological processes. Low amplitude responses with normal latency suggest a conduction block, while prolonged latency indicates differential slowing. Next is the latency. Latency is the time taken from the electrical impulse to travel from the stimulation point to the recording site. It is recorded in millisecond. It is measured from the distal stimulation point for the CMAP and for the SNAP, reflecting the time required for the impulse transmission along motor and sensory nerves, indicating neuromuscular transmission and muscle action potential initiation. Proximal latency and conduction velocity calculation. For motor nerves, proximal latency helps in calculating the conduction velocity by assessing the speed of impulse transmission over a large nerve segment. Now, latency measurements can be directly compared with the limbs to assess symmetry, assuming standardization distance between stimulation and the recording points. Next is conduction velocity. Conduction velocity measures the speed at which the electrical impulse is traveling along a nerve. It is expressed in meter per second. It is derived by subtracting the distal latency from the proximal latency, dividing by the distance between the two stimulating points. Despite being a fundamental NCS component, conduction velocity is often overemphasized, though it is not frequently abnormal in many neuromuscular disorders. It is crucial for diagnosing conditions like demyelination or nerve conduction blocks. Next is the area of the impulse. It represents the product of the evoked response amplitude and the duration, and it is measured in millivolt seconds for motor response and microvolt seconds for the sensory response. More accurately reflects the number of axons activated compared to the amplitude alone, but its measurement requires sophisticated equipment and can be affected by technical factors like interface cancelling. Now, standard and non-standard NCS. Standard NCS is regularly performed in electrodiagnostic labs. The studies provide a general overview of the limb nerve. And non-standard, it is performed as needed based on specific clinical situations to assess less common nerve pathways and conductions. So coming to the most important nerve conduction disorders that we see in our ICU. The first is the AIDP. So in the AIDP, in the first and the second NCS, at least one of the features of demyelination must be seen. So the basic difference, let's first understand, between AIDP and AMAN is that AIDP is mostly demyelination, while AMAN has axonal injury. So to differentiate between two, we will see how the NCS helps. So first is for the demyelination, the first thing that will be affected is the motor conduction velocity. The motor conduction velocity will be less than 70% of the lower limit of the normal. This suggests that the nerve impulses are moving more slowly than expected. Okay. The next is distal motor latency, which has to be more than 130% of the upper limit of normal. This indicates that there is a delay in the initiation of the muscle action potential after the stimulus, which is another hallmark of a demyelination disorder. The next is distal CMAP duration, which has to be more than 120% of the upper limit of normal. An increase in the time taken for the muscle action potential to occur and resolve implies the dispersion of the nerve impulse, which is often seen due to the demyelination. The next is proximal to distal CMAP duration ratio, which is more than 130%. When the duration of the CMAP is significantly longer for proximal stimulus compared to the distal stimulus, it suggests that there is demyelination, which is more pronounced in the proximal segments. The next is F wave latency, which has to be more than 120% of the upper limit of normal. F waves are late responses, as we have already discussed. They reflect the conduction time of the entire length of the nerve. A prolonged F wave latency indicates abnormal conduction, especially in the proximal segments. So we should see at least one of the following features in two nerve segment, which will signify demyelination, or one of the above and plus any of these features. That is, F wave absent in two nerves with distal CMAP of more than 20% of the lower limit of normal, which means that the F wave is getting transmitted despite a conduction block. And if this is seen in the two nerves but the distal CMAP is still above 20%, it implies that there is a serious conduction issue, but there is still some degree of signal being transmitted and there is some action potential still being generated. The next is abnormal snap. Usually the sensory is less affected, and here you will usually find an abnormal sensory response in the sural nerves while the ulnar nerve is affected. It is this differential type of this nerve affected. Both of these are indicating there is a differential effect on the nerves that are affected. So the demyelination is not uniform across all the nerves. Some nerves are getting more affected, which is a characteristic feature of GB syndrome. So the next is the Aman, where you initially in the first and second NCS you see no features of any demyelination, and in the first NCS that you find indicators like of axonal injury, like distal CMAP of less than 80% of the lower limit of normal, suggesting there is some axonal loss. Proximal to distal CMAP amplitude less than 0.7, indicating disproportionate loss of signal amplitude in more proximal segments of the nerve, which is typical of again a axonal loss. Isolated F wave absent for less than 20% persistent. The absence or significant reduction in the F wave indicate an inability of the nerve to conduct impulses back to the spinal cord, pointing towards an axonal dysfunction. In the second NCS, there must be evidence of axonal degeneration, persistence or further reduction in the distal CMAP, recovery of the proximal to distal CMAP amplitude ratio from less than 0.7. An initial reduction with subsequent improvement indicates there is some axonal regeneration. The second NCS indicator for reversible conduction failure, that is greater than 150% increase in the distal CMAP amplitude. A substantial increase in the amplitude without corresponding increase in the duration suggests reversible conduction block where nerves have begun to recover from a non-permanent damage. Improvement in the proximal to distal CMAP amplitude ratio. An improvement in this ratio by more than 2.2% indicates some recovery of the proximal nerve function. And the isolated F wave absence shows recovery of the absent waves without an increase in minimal latency, suggesting transient conduction block with subsequent improvement. So these are the basic nerve conduction differences between a demyelination and an axonal loss. So in critical illness, polyneuropathy is a neurological disorder often associated with severe medical conditions like sepsis or multi-organ failure. It is a form of axonal polyneuropathy that occurs in the setting of critical illness in the ICUs. The first thing that you see here is a reduced amplitude of the CMAP and SNAP. This indicates axonal damage. The muscle and the sensory receptors are still intact, but the nerves themselves are not conducting signals. The next is a conduction velocity and normal latency. This implies that the muscle itself can respond to direct stimulus and the nerves are also conducting normally. The next is the fibrillation potential and sharp positive waves. This is seen in the EMGs and indicates denervation of the muscles. There is spontaneous activity but occur in the muscle fibers which are not connected to a functional muscle. Now, decreased motor unit recruitment. When voluntary muscle contraction results in decreased recruitment of the motor unit, it suggests that many nerve fibers are not functioning properly. This can contribute to the muscle weakness. Then last is the large and polyphasic MEUA spontaneous potential. These changes occur in the motor unit action potential and typically seen in denervation. Polyphasic potential suggests that some nerve fibers are attempting to compensate for the lost connections, which are signs of chronic ongoing nerve damage. The next is critical illness myopathy. In this, what you see is the first a prime preserved sensory response. The sensory nerves remain largely unaffected in CIM, which helps in distinguishing it from CIP. The next what you see is a reduction in the motor response. Now this reflects the primary muscle pathology without nerve getting involved. It is suggesting the problem lies in the muscle ability to generate a response rather than the nerve's ability to conduct. The next is nerve stimulation, the repetitive nerve stimulation. Unlike some other neuromuscular junction disorders like myasthenia gravis, repetitive stimulation in CIM typically does not show any decrement, and this supports the myopathic nature of the disorder. The next is small short duration polyphasic motor unit action potential. These findings in the EMG are typical of myopathic process and indicate that the muscle fibers are not functioning normally. The reduction in and absent action potential excitability. The direct muscle stimulation resulting in diminished action potential is seen because of direct muscle pathology. The next is fibrillation potential. EMG findings of fibrillation suggest that the muscles are not functioning normally. And finally, decreased motor unit recruitment. This may be full recruitment pattern due to attempts of nerve system to compensate for the weak muscle response. Over time, as the myopathy progresses, and the recruitment also decreases despite the nerve compensating for it. So this is overall everything about the neuromuscular disorders. Thank you for your patience, and comment if you could not understand anything.